Welcome to Holistic Health for Happy Kids, the podcast where we dive into the root causes of children's health challenges and explore natural solutions to help little ones thrive. I'm Lisa, a passionate paediatric naturopath and mum of 3, dedicated to empowering parents with practical tips and expert insights to raise healthy, happy kids. Each episode will unpack common childhood health concerns like allergies, eczema, fussy eating, and gut health, and share evidence-based advice to support your child's wellness naturally. Let's create a generation of thriving children, one holistic step at a time. Thank you for joining me on this journey. Welcome to another episode of Holistic Health for Happy Kids. I'm your host, Lisa, and today I'm joined by Rebecca Khan, who is an occupational therapist specialising in paediatric continence and bowel health, which is a topic that I know a lot of us don't talk about, but it is an issue for lots and lots of kids that come to see us in clinic. So thank you for joining me today, Rebecca.
Hi, you're welcome.
So you're an occupational therapist, but tell me a bit about yourself and how you came to specialise in toileting.
It is an interesting topic, and I didn't just wake up one day and decide to work with toileting as a topic. I myself, being an OT, we work with kids with functional concerns and challenges and goals. And one of those is, of course, every day using the toilet. And so it came up for me as one of the areas that I was working with as a new graduate at a hospital here in Brisbane. And then over time, I actually was diagnosed with ulcerative colitis myself. So it's inflammatory bowel disease. And I guess then for me, I started to understand that it really is significantly difficult to live with a body that you can't trust, a body that feels as though, yes, you're having to get to doctors, or you're having to, it's not comfortable, it's not predictable, and it does really impact on your self-esteem, your feelings about going out and being confident, and even sometimes your relationships with other people. And so I guess I noticed I am learning a whole bunch of stuff for myself that was entirely relevant to this little group of kids that I was working with. And so I went on my own maternity leave and had to take a bunch of sick leave alongside that. And in the meantime, some people asked me if I worked privately, and I said, no, I don't. That is not what I do. I'm a public health practitioner. But I realized there was such a need. And I also realized I didn't know how long it would be till I could get back to working massive long days and, in the midst of my health travels. And so over the years, through word of mouth, I've gradually been working with many hundreds and hundreds of families with toileting difficulties. So both wee and poo and shoes. So there you go. That's the short, long version.
Well, it's great to have people who specialise in these sorts of niches where there is such demand, rather than just a general OT who might have a general idea of how to help and strategies to help, but isn't kind of stuck in the detail of it. So we'll start with toilet training and sort of the foundations of continence and toileting. So how do you define readiness when it comes to toilet training? So, what do you look out for? Obviously, it's more than just the number on your birthday. So what do you look for?
That's right. Number can give us some information, but really it's understanding where a child is at developmentally. Are they interested in their body? Are they noticing their body signs and signals? And often with their behaviours, they might not even be able to explain a lot about that yet when they're little, but they might be coming up to you and saying, oh, I need to, they're pulling on their nappy, or they're coming up close when they need to be changed. And so you'll start to see that they're responding, maybe not even to the urge, maybe it's just more to the fact that they've become wet or dirty and they're uncomfortable, or they've noticed the change and they're seeking assistance from their primary caregiver usually to help them out with that. So they've noticed that something has changed and they want to do something. So you're seeing that there's a bit of an initiative or a notice that their brain is helping them with. And so that's a fairly sensory element, but it's also a cognitive choice to be involved, or like a motivation factor that their brains will come to at different ages and stages. So they might be very small. They might be not much more than 12 months when they start doing that, but they might be much more than 2. But really, that's one of the early things we look for. Another one is that they can physically participate in elements of being taken to change, or to be pulling their pants down, or to be, maybe opening something or holding something. Of course, they need to be able to sit up and participate, maybe in sitting on a potty or something like that. So there's a few motor skills as well that's helpful to sort of see. Now, they don't need to be fully developed yet, but that we're noticing that they're along the journey of building those skills. So they might still need a hand to pull their pants down, but the fact that they're starting to learn it, they're interested in it, that's a really lovely sign that, oh, it might be coming up soon as well. So there's probably a couple of key elements. Probably with readiness as well, and a big one that we overlook is that they have a healthy body. Now, by saying this, I don't mean that if they're not healthy, you can't start. But what I mean is if their bowel or their bladder are continually experiencing things like constipation, urinary tract infections, then it's very, very hard for them to get reliable urges or to feel comfortable around this part of their body. So for us to come along and give them a lot of expectations on new skill development, it can just be very confusing, and we don't get very far. We all get frustrated, and sometimes we can miss the fact that actually they just need to go to work on those other issues, go see their family doctor and sort that out before they start. So there's sort of the health side of that. Having a healthy bowel and a healthy bladder is a really wonderful place to start if you're not sure as well.
And something that gets diagnosed a lot is toddler diarrhea, which just drives me mad because what a vague description. But obviously you've got this toddler diarrhea, which is usually a reason for it. It's usually too much fruit or something. Then yeah, you're not going to be able to control that because as an adult, it's very hard to control it.
Exactly right. Yeah, loose stool doesn't give you a lot of feedback to tell you when your bowel is full and needs to be emptied. And so it can be very confusing for the kids because sort of, as a fastidious parent, you might be coming along saying, oh, that poo, it needs to go in the toilet. And the kid's like, I didn't know it's coming. I had no idea, and that there's the trigger for toileting in the toilet or, in a potty is absent. That trigger of the awareness before it comes is absent if they're not experiencing that sort of healthy filling and emptying pattern with healthy poos and wees. Mm-hmm.
And do you think there's like an optimal window for toilet training? And if you miss it, it really sets you back a bit?
Yeah, it's an interesting question. When you look at some of the literature in the medical science, there's a bit of conjecture or sort of vague ideas, I guess. What we do know is that it is easier to get some of our younger kids to participate in new skills before they learn that they can say no. So we do find there is a bit of a window, especially if the child is, their bowel and bladder is healthy and they're interested in learning to listen to their body and they're learning to follow instructions and learning to come with you and participate in new tasks. At around 18 months to 2 years is actually a really lovely patch to give them a try. Now, it is young, and in fact, that's a lot younger than our average successful toilet training age. But we need to remember, even just a couple of generations ago, the average age for toilet training was 2 to 2.5, and that's when they finish. And so in a couple of generations, we've actually bumped that out to more than 3.5 years. But it doesn't mean that our brains are dumber and we can't learn that. It's just because we've changed the environment. And we also know there are sort of higher rates of some of these difficulties with allergies and other things that interrupt those messages. But really, kids do have the capacity to learn a lot earlier often than we give them the opportunity. Now, having said that, I just want to caveat that, in fact, we don't want to be putting massive demands on a child who's not ready. So we still need to factor in that some of our little people are just simply not ready. But if they are, I encourage people to give it a go because it's easier to take a little, 20-month-old with you to go, oh, look at this, everything's fun, compared to a teenager who's decided, well, you think that's fun, but I'm going to have my opinion about that. And they're sort of better and more sophisticated at pushing back and pulling out bigger behaviours sometimes by that age. So, it's something to look at least. Have a little try, but not overwhelm them if they're not ready.
I'm glad you said that because my observation is that some cultures, and specifically I'm thinking of Eastern Europe, Eastern European people that I have met all have their children toilet trained before too,
Yes.
and like night and day. And I was
Uh-huh.
like, wow. And do you think, obviously there's lots and lots of reasons for that, but another reason I've heard, and I don't know where I've heard it or if it's true, but moving from cloth nappies where you feel that you're wet against your skin to disposables, which take the water away, make you feel dry as anything. Do you think that's been important in the change over the last like 50 years in the age of toilet training as well?
Definitely, yes, it is that, and you've just again, it's that sensory difference that we're experiencing that the child just is not aware that they're wet. They might be aware for 1 second or 5 seconds tops, and then these new products we have are so good at wicking away the fluid from the skin, which is really important if you've got chronic incontinence and you're in a nappy all day, for example. We don't want the fluid sitting on your skin. So but that's a different use of continence aids. Unfortunately, in our early years, we're using nappies in that way when actually we should be more in a skill building phase where we're giving them opportunity to respond to what their body is experiencing, but we're taking away the trigger. The trigger of feeling wet is sort of missing, or at least very brief. And so the child can easily just ignore it after 5 seconds and they don't have to think about it again until someone comes along and says, oh, you're wet, come on, let's get changed.
Yeah, yeah.
So yes, it definitely is a factor. There's also the factor too, alongside that. I know as a parent, I chose to try some washables early on. My kids are much older now, so this was back in the new millennium. But I used disposables because that was what I managed. I had 2 kids close, and that's what I needed to do for my own sort of routine and mental health and different other things. But we also have to make the choice to take them away at times, or to have a try, to give them an opportunity to be able to learn or have a go and see what their skills are at. If we just leave them in them for 3.5 years and say, I'll do that later, well, unfortunately, they've had 3.5 years of practice at pooing and weeing in a nappy. Whereas if we bring it a bit earlier and put it into their skill building phases earlier on, it just becomes an accepted part of life, is that as they move through their skills, this is just another skill that they're moving through.
Yeah, and
But
you can
again,
always do a combination of
that's exactly
disposable
right.
and cloth nappies to
Yes,
give them that experience.
that's right.
So we see a lot of children with daytime urinary incontinence. What are the most common causes that you see for that to happen?
Definitely. One of those is anxiety. And by that, I sort of mean lower anxiety. I don't mean kids that have been necessarily diagnosed with that. Some of them have. But really, it's this sort of hypervigilance where they're very worried of making a mistake. And so they will go too often. And they will be peeing all the time just in case. And often it's actually we very stressed, anxious adults who are saying, quick, get the toilet. We're getting in the car. Quick, we got to the shops. Let's go get to the toilet again before we do anything. And all the time we're putting on the toilet. And what actually happens is the bladder learns to only empty a small amount of wee all the time, instead of letting that bladder fill up nice and full before it needs to go. So sometimes it's the way that we've kind of almost been too excited about getting them on the toilet too frequently, and then their bladder has never had the opportunity to hold a whole wee before it then gives that urge to squeeze, and then off it goes. That's one. One of the main reasons too, especially as we get a little bit older, is urinary tract infections. I just want to highlight too there that urinary tract infections should be quite rare in children. So if we're seeing recurrent UTIs, we do need to get that checked. We need to check that the bladder is emptying effectively. We need to check that they don't have sort of a treatment-resistant UTI or some other issue going on. It can be a sign of a few nasties in children. So definitely get that checked if you have a child who has any more than one UTI in a 24-hour period, 12-month, 1 year, any more than one in 1 year is considered to be abnormal for children. So just just note that. So that's another reason, of course, because of the pain, the burning, the stinging. And the other main reason is postponement. So just holding for too long. And that's a combination of not feeling able to go because I'm at childcare. I don't like the fact there's no doors on the toilet. Maybe it's because, they're just too busy playing. They don't notice. Some of them have like a demand avoidance, and so any sort of demand from the external world, they just sort of say no, but unfortunately they can't hold it as long as they think they can. Can also be a judgment problem where they just they're withholding because they think they can hold for long enough, but actually they don't have the muscle tone or the pelvic floor control to be able to hold that long. And so, even on the way to the toilet, that's the classic. It's like, I'm coming, and then all of a sudden it's running down their legs and they're halfway there. They just haven't given themselves enough time. And judging time is a classically difficult thing for kids. They don't, our understanding of time develops much later. And so certainly if you have a little person who's much more interested in playing or doing something different, they can often be caught out by withholding. So it's really going too often, or withholding for too long, or that more rare one, which is the medical sort of having too many UTIs.
I think it's quite odd in daycares where they have the bathrooms just with all the little toilets lined up. Are all countries like that, or is it just Australia?
I agree with you. It is a part of our Australian standards, Australian building standards, to have vision by the caregivers at all times in childcare centres. And so they just, at some point, took the partitions away. It's not everywhere in the world, but in many Western contexts. Unfortunately, we do know that starting daycare is actually, and same with starting prep, they're common times for children to first get constipated or first have toileting problems. So you have little people who never had a problem in the past, they were toilet trained, but unfortunately things have gone backwards, and often it's because they just do not use the toilets when they're out of home at daycare. And so they're holding for far too many hours. And that's when you can start to get things like, UTIs or just have the leaking. And their poor old bladder doesn't know what to do because it's so stretched and wobbly after holding a giant wee for so long. And they often have, like a little weak pelvic floor by the end of the day too. So often kids will be continent at school or childcare, but they'll get home and have a bunch of accidents. And that's sort of a classic sign too, that they're holding. But unfortunately, the day is too long. Their pelvic floor is not able to last that long, and it starts to leak by the end of the day.
Yeah, I can't imagine like a 5-year-old sitting down and going to the toilet in front of all their friends. Like, it just seems a bit.
It's absolutely, and it's everyone's worst nightmare. And in fact, I really encourage. So often, one of the ways that we work with that is encouraging and talking to, advocating on behalf of the kids, talking to their educators, asking if there is like an adult toilet that we could use for that particular child. That especially if they're in long day care, that we need to give them privacy to be able to poo and wee when they need to. And so often that will just look like getting permission specifically for that child. That they'll often need to leave the door open, but at least they have, so that the caregivers can see them, the educators can see them, but at least they will have, walls around them and no child sitting next to them on the next toilet, or an audience of people watching on.
Funny.
Yeah.
So encoparesis, it's funny because I literally had a child yesterday, and this was what the issue turned out to be, was encoparesis. So do you want to explain what this is, why it happens, and why is it not kind of more widely known about?
Definitely, yes. Encoparesis is one of those terms that has been used differently across different contexts over the years. And so what we're finding now is the international guidelines are to call it functional fecal retention, which is not any more helpful. But basically it means that the child is experiencing leakage of poo. In most cases, that is because of constipation. So if you have a little person who is either toilet trained and regresses, or they've really struggled to toilet train and they're beyond 4 years of age, encoparesis or functional fecal retention, or just soiling, if you want to just call it something like that, fecal incontinence or soiling, there's a 95% chance that it's caused by constipation. So it's quite an interesting number that really, it's very, very common that what has happened is a large poo has been held or retained in the bowel. Often it's over many days, weeks, months, or years. And unfortunately, it's dried out because the large intestine just keeps drying out our poo. It doesn't have an off switch. It just keeps drying, keeps drying, and keeps drying. And so if a little person holds for too long, even an adult, then of course it gets hard, it gets sort of bigger and lumpier and more like a piece of concrete rather than a soft, smushy poo. And so when they do go to pass it, they can't get it all out, or they just do little bits, or none of it comes out. But what we do get is we get the loose, like the sort of more runny poo that's from further back up the large intestine, leaks around the outside of the hard, dry mass, and it leaks into the undies. And the child genuinely has no awareness that anything is coming out. out. So it's a little bit like a rubble drain, or like if you've got rocks and then the water runs around and heads out the other side, but the rocks remain, and it's a bit like that if you think of it from a sort of the physics perspective of what's going on. But the way the bowel gets sensation is actually when it fills up. So when we're resting and when we're nice and empty and when we don't need to poo, our bowel should be completely relaxed. The sphincter is naturally closed all by itself on the inside, and then our external poo hole, the external sphincter, is open. We can relax that. We don't need to hold it closed because inside is empty. And that's that last 10 centimetre of the bowel. It's nice and empty. But when it fills with poo, that's when we get the urge to go, because the muscle stretches. And so if the child always has old poo sitting in that last 10 centimetres particularly, then it doesn't ever get the sensation of being empty to then know when it fills up. And so we find that genuinely the child will say, no, I don't need to go. There's nothing happening. And then, moments later, there's poo leaking out. Often it's loose, runny poo. We don't think that they're constipated because it seems really runny, but in actual fact, there can be hard, rocky lumps inside and just the loose poo that we see coming out. But either way, they don't have sensation. And also the muscle itself is very stretched with constipation, especially where it has gone on for a long time. And so we know that muscles that are well stretched, or stretched too far, they don't have good response rates. They don't tell us what they're doing because they are just far too stretched. They're not in a lovely, happy, healthy, compliant, stretch release kind of, or stretch relax kind of pattern. They're just on stretch. They're floppy when they do get emptied, and so the muscle itself doesn't have good muscle tone for emptying or good muscle tone for feeling the difference between full and empty. So yeah, it becomes a whole picture that often looks like runny poo leaking out into underwear, the child having no idea or genuinely in denial, because by then their brain is getting very concerned and confused, and they're a bit overwhelmed by this whole awful problem that really, so they present with this sort of fecal incontinence, sometimes tummy pain, but other times they're so used to the feeling of having a very full gut that they don't even report any tummy pain either.
Yeah. So if your child has skid marks, constipated.
Yep, 95% chance. Yep,
yeah,
that's right. And it's literally, there's only a 5% chance it's something else. So it's that sort of thing. And then the action really is to go and talk to a doctor, talk to a naturopath, talk to someone who can help you figure out how to get that bowel empty in a way that's lovely and that's not scary or frightening to add layers of difficulty to the problem.
And then maintain being not constipated with prebiotics, probiotics, food changes, whatever, to keep what I get people to do is to do something called the sweet corn test. I don't know if you've heard of that.
Yes.
So you get them to take the sweet corn, see how long it comes out. And if they have that backlog of poo, then that sweet corn won't come out for a very, very long time.
That's right. Yes,
it takes. Say they're impacted if it takes like 48 plus hours.
Yeah, that's right. It really does. It takes that couple of days to come through often for these kids, but it will often take a really long time, or you may never see it if they're very constipated. We've had kids that have passed capsule casings, so from some of their other medications that they take for other reasons. One family we were talking to, they said they saw the purple capsule casing come out 6 months after they stopped taking that medication. So it's literally like concrete that has just, everything just gets added to it. It's like a traffic jam, and there's just cars joining back on the end of it. So my sort of rule of thumb is, if in doubt, wash it out. Like, if in doubt, we've got to get it out. And if you haven't seen it come out, then it's still in there. If that sweet corn hasn't come through, then it's still in there. It's just a tube. The large intestine is only absorbing water. It balances salt just a little bit, but mostly it's only absorbing water. So, we would expect to see something like sweet corn. Another little one you can try is having a bit of food colouring in Wheat Bix, or something with a lot of fibre, so oats. We do blue, like Elmo porridge. And then have that and see if that comes out the other end.
Yeah. Oof, can you imagine?
I know.
And so constipation, so we've talked about constipation. What are the red flags you would say in these sorts of situations, because a lot of people will just think that a child is being belligerent when they won't go to the toilet, hence they've got skid marks. So are there any red flags other than doing something like the sweet corn test that, you should seek specialist support rather than just kind of, doing behavioral strategies?
That's right. Yeah. Look, the gold standard for kids is definitely to go and get the child seen by a doctor. They should be able to lie them down and feel their tummy to sort of have an idea about how much is in there. So if you think about having, months, literally months, many of the children we talk to have got months of old poo in there. What we don't actually want them to do is suddenly poo that all out in a day, because it will tear their bottom. They'll get very scared. And we might actually end up then with a trauma or additional trauma layer on top of what's going on. So we often do need to soften down what's in there to get it out initially. So just, making sure that we are sufficiently aggressive enough in terms of what we use to get that out. Then we need to keep it out, as we said, and we need to keep it out for at least 6 months. So what that looks like is a combination of fluid, stool softener, fiber, probiotics, all the various things. There'll be a combination. Every gut is a little bit different, but we need a sufficient plan to have that child pooing a whole poo every day comfortably. So it's a soft, non-scary poo every day. That's when we just keep that going for at least 6 months, because it takes that long for the muscle to heal. So it really is a long-term plan that we need, because we don't want this to just recur. So we also know that once you've been quite constipated, or if you're a person that gets that a little bit, you are very likely to get it back again, just because of your lifestyle issues, but also potentially your microbiome, your activity level, just genetics. There's all kinds of reasons. So really what we want to do is make sure that we are having a plan that not only looks like how do we get this out, over the next sort of week or two, but also how do we keep it out. And the other thing that happens over that 6 months is that the child sort of forgets that pooing is hard. They forget that it hurts. They learn to listen to their body. They're learning to eat a little bit better, drink more water, all the little things that might have been a factor in the first place. But primarily there's a fear-based issue that is maintaining this problem that we also need to work on through that time. So that sort of 6 months minimum of like a nice scaffolded sort of close monitoring treatment plan is what we actually need, not only for the physical recovery of the bowel, but also for the child to calm down around the issue, relax some of their pelvic floor when they do go, learn how to use the toilet properly, learn how to relax and really empty out effectively every day, rather than just sort of letting little bits sneak out here and there, or just having no control. So there's quite a few skills we're building in the background for the little person who has had constipation as well.
I think it's a really good idea for parents to actually just feel their kids' tummies regularly, whether they're constipated, not constipated, sick, and just understand what it should actually feel like, so that whenever something does happen, they know they can feel the difference.
That's right. Yeah. And often too, you can definitely palpate, or that, feel the tummy, and you can feel the difference. Let's say they've had a week where they've really gotten out a bunch of poo. You can feel the difference. You'll usually see their belly come down. They're not as bloated. They'll often get hungrier. A lot of our heavily constipated kids get really dark under their eyes. They're a bit sluggish, very, very putrid, stinky farts. Poo that smells like it's kind of crept out from under a rock somewhere, like something awful, something died. Poo shouldn't smell like that. Poo should be nice and sort of fresh, more like it's been a farm, that sort of organic smell. Yeah, that's right. So there's, it's sort of a lot of that learning too about, what we had wasn't normal. We now need to learn what is our usual happy, healthy daily bowel rhythm that is comfortable, that is regular as well.
And so when someone comes to see you, first of all, like as an occupational therapist, what do you observe? How do you assess them?
That's right. We do a parent session first, actually, just to talk with parents about what the journey has been. There are often pointers or little flags back in their early childhood, or some early things that help us understand whether it might be primarily a medical sort of reason for which this is happening, whether it might be more to do with some of those more lifestyle things, which, things like food or drink. And we know lots of our kids really struggle with the variety of what they're able to take in orally. Occasionally, there's some things in their family history as well. We know that there's a higher incidence of bowel and bladder issues in children with neurodivergence as well, so and adults. So there's often sort of little pointers, and sometimes this is the issue that shows the most significant functional impact in those early years, but not always. But there's lots of those little things we're looking out for in the assessment, and we do that with the parents first so that the child's not listening in to hear a negative story about them for an hour, because usually this is already such a tricky topic that we just don't want to add layers of stress to that. So we'll meet the child at the next session, and depending on their age, that will look like sitting down with some kids' anatomy books and talking through how the body works and what sensation is, what does it feel like, what's full, what's empty, what's relaxed, what's tight and full. Or if they're a bit younger, we will do the sort of role play steps with mini toilets and potties and little characters and puppets and, all kinds of other things as well to play through what is otherwise a very stressful topic for them. So yeah, we see kids anywhere from about two and a bit right through to sort of 18. So yeah, we grade that depending on where they're at. And of course, the older they get, the more we engage their own brain in sort of thinking about and self-reporting on what they're experiencing, what they might be scared of, or just how they're coping at school, what is their plan, and troubleshooting some things with them as well. So there's many, many factors. I love that about my job. It's very diverse. So we do, you've got a toilet everywhere you go. So school's relevant, home's relevant, camp is relevant. Yeah, so there's lots to cover.
Yeah, I agree about talking to the parents beforehand. We do that with our clients like most of the time because kids just don't need to be bothered by these details. They need the kind of the outcome of the sessions, but they don't need to be bogged down. And the whole family can get so whenever toileting is an issue, same when like fussy eating is an issue, or whenever there's an issue, the whole family can just get so fixated on this one problem that it can be exhausting for everybody.
Definitely, yeah. We see that a lot, and managing that context as well is really important. So we do use parent coaching as one of our key treatment strategies, actually, just because it is such a stressful topic. And it's also very isolating as a parent because it's not the sort of thing that people generally chat about over the school gate or at pickup. There's just a bag of stuff that you've got to go and collect somewhere, and it can feel very embarrassing and very stigmatized. So so having that safe space just to debrief, to talk through what we've tried, what's working, where the positives are, but also what's continued to be difficult as well.
Yeah. So withholding is something that we haven't talked about, but withholding is basically where a child, stops going to poo because of some traumatic experience, like they've been really constipated or like, they've had a preschool situation. So I have some non-evidence-based strategies that I use for withholding. So they're non-evidence-based, but they're extremely effective. And our number one strategy for that is a flower remedy. It's called bottle brush. So the lovely Australian native red flower that looks like a bottle brush. Using that for a child who is withholding can work amazingly well. There is zero evidence behind that, but we know that it works. So tell me, what are your evidence-based strategies?
That's right. When I'm working on this issue with families and kids, I really like to think about the fact that they've got to live with this gut and their relationship with their body forever. And I think that's also informed by my personal journey with my own self. It's that sort of coming out of that, how do we fix this one problem today, to how do we not just have it keep coming back? Because the more I worked with these kids as well, the more you can see that it can become such a cycle that just goes on and on and on. So you need the things that you do immediately, but you also need that broader plan of how we're going to embed routines, patterns, diet, fluid, positive, thoughts about my body, listening to my body, judgment, cognitive decisions. How do we have a whole wraparound sort of idea about how we're going to think about our body into the future? We know that the rate of constipation in adults is at least 20%. They're the people who actually report. So it's also not a problem that disappears after childhood. And so that's where we sort of go, if we can teach a little person to listen to their body, to think about, I'm about to sit down for my, screen time today. I don't want to get interrupted. I'm going to make the decision to go to the toilet before I start so I don't get interrupted. So little things like that. Now, as a parent, you can come along and tell your child to do that. But for them to actually start to understand it's their body and they're in charge of those decisions. And of course, you can get further with that as they get older, but still it's around language. So it's about, I'm looking after my body, I am healthy, I am hygienic, there's a bit of an accident, but I'm going to get involved in cleaning up. So a lot about their participation in that tidy up. Now, we also find that in that immediate phase, making sure that that constipation has been emptied is one of the really key points. Because with withholding, the kids get so used to it that they don't know what empty and relaxed feels like. And so we do also a lot of work around supporting families to access care to be able to get that empty, but also teaching the child that empty is the aim, that, and what that feels like, that it's relaxed, because a lot of them are not even aware that they're withholding. So this is a little bit like, if I'm super stressed or doing too much computer work and I've got my shoulders up around my ears, someone says to me, relax. I'm like, I am relaxed, I'm fine, but until you go to some massage or somewhere that they actually put their hands on it and you realize, oh my goodness, and you walk out and you feel 3 inches taller, you don't realize how much tension various muscle groups are holding sometimes until there's an external prompting and ways to check. So now the trick with this is we're talking about the pelvic floor. Now the pelvic floor is a personal, private area, and it's an area that, particularly in children, we don't want to add trauma, we don't want to add other things that are going to layer concern into over time. So we can't just do palpation, for example, which is where you feel the bottom, relax those muscles, etc. And in fact, gold standard is to not go there, basically, unless we're just doing general cleanup, the kind of stuff. So it really is looking at teaching the child some of their deep breathing, how they're sitting in the right position, which is actually more like a squat, getting their knees up above their hips, getting their pelvis open. So the knees need to be wider than their hips. We don't want their knees jammed together and tight so that they're actually, they look like they're pushing, but actually what they're doing is they're clenching. We want those knees wide, feet flat, and really high knees so that we're tilting the pelvis forward, opening up the pelvic area so that the muscle of the rectum can actually release and let it go. And it's the same position for pooing and weeing to get that really lovely complete emptying. And one of the biggest issues too with little people, because again, time and paying attention is tricky when you're little. That's just, your brain's still developing. Sitting for long enough, staying. So we'll look at little strategies. I like using little oil timers, that little sort of you just watch the oil go through the little spinner, something nice and colourful, looks a bit like a lava lamp or something, it's something that you can just watch and notice while you're sitting in that great position, just relaxing, deep breaths into the belly, so lovely diaphragmatic breathing in that position, and then moving through to thinking about my bottom. Has it emptied? Does it feel empty now? And then learning to wipe and get off. So there's multiple steps, but certainly relaxing and understanding how to let the hole go, like let it out. That's one of our first sort of go-tos after the child has been empty of the old poo.
And the toilet seats that you can buy that go over the toilet for little people, they're the worst possible position, aren't they?
Yeah, there's some really awful ones actually out there, to be honest. Look, it's a lot about fit to your exact toilet, because our toilets are too big. In fact, they're too big really for adults. All of us probably should really be squatting over more Eastern style toilets, but a lot of us can't get back up again. So we've got this cultural problem. However, for our kids, our toilets at home are too tall. So you think, okay, yeah, we'll get one of those ladder, the ladder child toilet seat things. But unfortunately, they're often wobbly, they're often ill-fitting, and you can't get your feet wide enough or flat enough on those usually. Also, when you go to climb up on them, you put one foot on them and it wiggles, and the child instantly goes, this is not safe and secure. A bit like if you sit on a bar stool that's wobbly, you're like, I'm getting off here right now. I'm not feeling safe up here on that wobbly thing. So really thinking about, one thing we really love is the family toilet seat. So you can get to a hardware store and you just screw off your old toilet seat and you put one of these on. Check if you've got a D-shaped seat or you've got an oval seat. Take a photo of your toilet with you when you go or when you're looking online. They cost up to $120, between about $60 to $120. But basically it's got the lid, it's got a small child size insert that also is hinged to the seat, so it lifts up, and then you have a normal adult size toilet seat on there as well. So you've got options. You're not lifting it out and having to keep wiping, changing it and moving it around. It just stays on the toilet. Great for siblings if you've got a couple of kids, and also any visitors, but the adults can use the same toilet easily too. But then, of course, that's only the seat to make the hole smaller. Then we also need to get the step stool for their feet to go on. So you can get a couple of different options. If your child has pretty good balance and they're fairly physically capable, just getting a nice tall plastic step stool that's nice and wide is good. Now, I'm not talking about one that's 10 centimeters high. It needs to be at least as high as close to the back of the child's knees. So we only want a little bit of space between the bottom of their feet to the edge of the toilet seat when their feet are on the seat. So there's some of these at IKEA, some of them you find sometimes in cheap shops, but yeah, it needs to be a little bit tall, a little bit wide. You can custom make those. You can also find some online as well. So have a little look around and try, but look for the width. It also needs to be very secure and sturdy. We don't want any wobbling or moving around. It needs to be very sturdy for the child to relax their bottom effectively. And also if you've got a nearby sort of, think about where they're going to wash their hands. What usually happens is you buy one and it gets moved over to the station where they wash their hands and then it stays there for a year. So buy two or buy a proper step for the basin as well. So don't forget about hand washing and things later too. So that's just a couple of little tips for that. But yes, certainly setting up your toilet in a way that is conducive to the child getting in a great position is an excellent way to start.
And some kids, and they will wait until they get their nighttime nappy on, and then they'll go and sit behind the sofa and squat into a poo in their nappy.
Yes.
Really, those are the kids who are trying to get into the anatomically correct position.
Absolutely. It is a massive positive. Yeah.
And this is going to sound extremely weird to most people, but what you could actually do is just put a piece of A4 paper on your bathroom floor and said, poo on this. Because then instead of getting the nappy association, because it's nothing to do with the nappy, it's just poo on the paper, I'll flick it into the toilet later, and they're in the right position. You don't have to spend anything.
And this is the thing, we find this too with extended nappy use. If you're in a nappy, you can poo anywhere while you're doing anything. And a lot of kids stand up. So one of the hardest things for them, if they've been practicing standing up to poo for 3.5 years, and then we say, here's a toilet, now you're growing up, let's try this. They don't know how to get the poo out in a seated or squatted position because they've sort of been standing and doing some strange maneuvers, to get it out. That's just how they've learnt to activate muscles and relax other things. And so it's also one of the reasons we go, yeah, when they're little, they are so quick and great at squatting. If you've hung out with a little 18-month-old lately, they just get up and down, and again, caveat there, if they've got lower muscle tone or they're slower with their gross motor skills, just add months for that. But really when they're shorter and smaller, popping, paper idea is fine. The toilet, like a potty even, just popping a slide a potty under them, wherever they are now. So if they're squatting now in a nappy, I always like to encourage families, it's fantastic because they're going every day, but what we want to do then is we want to enable the location, maintain the squatting, transition to something else. So it might be the poo mat, it might be a mat that goes there behind the lounge, and then we move gradually towards the toilet room. So the mat comes with us, and maybe we leave the nappy for a little while, but then we bring that and then gradually we take it away. So it's just little steps at a time. We know when we're dealing with things that are connected to fear and worry, which toileting in this regard, particularly the toilet withholders, it really is connected to some kind of fear, either recent or a long time in the past. We need to go slowly. We need to be predictable, and we don't want to add panic or disorganization to the situation for them because their brain just continues to demand more control to try and mitigate their own anxiety and protect themselves. So really looking at having a nice clear plan that's very, very gradual. Make sure you establish one skill, one little mini step before you then add the next little step, which is taking us a little bit closer and closer to the main goal, which is going to be putting or being on a toilet.
Yeah. So what about kids who have been toilet trained, but then they regress, which is something that I also see a lot, and I see them regressing mainly with wheeze, but sometimes with poos as well. So we start with wheeze. What about the kids who have toilet trained fine, but then they regress?
Definitely. They often, one of the main reasons actually for wee problems recurring or sort of turning up in a child who's already been toilet trained and been independent for more than a few months, it is actually constipation. So because the bowel and bladder are so close in the pelvis, if the bowel is full, even with a couple of extra days of poo, not even hectically full, but it's just that in a little child's pelvis, there's not enough space for a whole, couple of days of poo as well as a full bladder. And so the bladder needs to squeeze sooner. And because, of course, it has fluid, it comes faster. We just like, oh, there it is. And we know that about 2/3 of wee problems are actually, alleviated by looking after their bowel. So that's one factor. And that's the same for bedwetting at night. That's a classic issue for occurrence of bedwetting at nighttime in a person who was dry. So then once we've checked the bowel, sometimes it's not the bowel, sometimes it's something else. We check for any UTIs or pain, fevers, discomfort, grumpy behaviours that are sort of like, oh, they're getting sick. Like, what's wrong with this kid? I find a lot of kids don't report pain with UTIs. Sometimes they've had a number and they're just, they're a bit low reg. They just don't notice, their sensory skills are such that they don't notice a lot of pain in general, or they can't verbalize it, they can't explain it. And so we just get it checked out. If in doubt, check it out. And then sort of go, okay, it's not bowel, it's not a UTI. Is it possible? Like, let's look at, maybe they're not weeing at kindy, or what is their sort of pattern, and just helping them to learn again. So we'll often look at drinking, look at their drinking as well. Are they just having a little sip every 20 minutes, or are they actually drinking 150 mils, then having a break for an hour, and then drinking 150 or 200 mils, having a break? Our kids are sipping a lot these days on bottles. Much better to actually give them a whole drink with full gulps, full swallows of water. Much better for their oromotor skills as well. And then teaching their bladder to be able to fill up, empty out, and then rest for a little while. Now, of course, their bladder is going to be receiving fluid all the time because it dribbles in. But you know yourself, if you have a nice big drink, then there's a really good chance that within a half an hour, you're going to be like, oh, yeah, I need to pee. Like, I need to go. Your body really gives you a strong message. And so that's one of the tips that we also can use with the bladder is sort of timing a little bit. And we don't need to do that whole drink every, 30 minutes. I like to keep it very functional, again, with that long-term view. Have a drink at breakfast, have a drink at morning tea, have a drink at lunch, so about 6 times a day. I'm in Queensland, so we have hot weather. We'll always encourage like an emergency drink as well. So that might be, after soccer at lunchtime, or, whatever the other sort of the big activity, or the big sort of sweaty moments when I'm thirsty. Absolutely drink, but then let the child know that we've filled your bladder up. Soon we're going to need to go and empty it out. And you can do it together even if you're at home, which is a nice way to do it too. Let's have a big drink with morning tea, and even set a little timer or do a bit of an experiment and see, I wonder how long it's going to take for us to get that strong feeling. Do it together and see what happens. So yeah, there's a few little ways, but definitely there's some tips for the bladder.
That's a good one. So you train parents and professionals on these topics. So what's the biggest gaps that you're seeing with clinicians about what they've been taught about continence?
There are massive gaps, and I know that's part of why this becomes such a problem, because a lot of people, if I send 5 of my families to 5 different doctors or other professionals, they'll get 5 different answers in many cases. There are clinical guidelines out there, the information is there. I guess it's not usually a life-threatening concern, and so it doesn't rank highly on your average clinician sort of level. So in standard public health, for example, life-threatening things, of course, get more attention. The problem is that these issues, they go on a long time. They affect your mental health. They affect your family cohesion, your sense of self-worth, your capacity to progress in your education. There's all kinds of other factors. So they're huge problems. But I guess because our public health is skewed towards life-saving, which is fantastic, but it doesn't get that attention. So then you get the runaround. You might be lucky and find someone who knows more about it, but you also might not. And so we just find that there's lots of varying messages, which is very confusing. So hence why I've been busy trying to teach more clinicians about, how to do this sort of base level management of these kind of conditions. But that would be one of them. I think probably another one is just actually being able to not only get the child's body to a healthier situation in the first place, so treating the UTIs or the constipation or allergies, often sorting that part of it out first, but then understanding that we need a plan that goes on into the future. So often kids will have had some great initial intervention, but no one has said what to do if they don't poo for 3 days next week. And so we use things like rescue doses of stool softeners, or going, I'm going to notice by Friday night how many poos did they do this week. Okay, let's make sure this weekend we do we action their go-to rescue plan, which might be, lots of activity. Some kids will poo every time they swim, like they'll go swimming and then afterwards it's like, oh, there's a poo. Lots of movement, lots of fluid, might be stool softeners, all kinds of things. So yeah, we need to not only look after the now, but also the what does the next few months and then embedding this into this child's life habits look like.
Yeah. And I'm sure you're a very busy woman because this is such a big issue. So how can people work with you?
Definitely. Look, always get in touch. I've got a clinic called Kids That Go here in Brisbane. I'm about to launch an app for parents as well, and that will have a bit of a community as well on it. And then through clinicians too. So we often do some, if you are a person who's had to engage like an OT or physio or somebody to work on this skill, certainly we often do specific sessions as well with clinicians to just sort of boost their skills and support them to continue to support you as well.
So tell me about the app.
Yeah, it's called Be Brilliant. And it's around, just parents being able to get sort of some of this up-to-date information embedded in practical ideas and just really practical ways to implement some of these changes in the day-to-day. I think I find I've been doing lots of parent education over many years, and it's just so hard, isn't it? Your brain's full of all the new ideas, which is fantastic, and you might be able to implement a few, but then you just forget stuff. Whereas with an app, we can add notifications if you want to have them, or we can add community chats, or you can ask for certain topics and I can jump on and do a new little webinar or do some Q&A live, those kinds of things. So it's just a little way, because I've just acknowledged in many cases is not it's happened once, it's a 3-week problem and that's the end of it. For many families, it just goes on and on and on. And so the idea is to upskill parents to be able to just really feel on the front foot, to know exactly what works for their little person. And it's often not just one thing, it's multiple sort of little tweaks and tips here and there with varying aspects of lifestyle and, diet and all kinds of things as well.
So people just go to the App Store and look for Be Brilliant?
They will be, yes, it will be on both app stores. I will be putting that via my website probably, but I can share on links or other things as well when it's done. I've been rapidly videoing and trying to check it all and make sure that it's up to date. So it's not launched yet, but it won't be too long.
Okay, that's awesome. Great. So is there anything else that we haven't talked about that you would really like to share with families who are affected by these issues?
Yeah, I really want to encourage parents to be confident that you know your child the best. And if you feel as though there's something not right with the management that you've been given or the way that you've been looked after in, varying healthcare or other settings or with clinicians, just, encourage you to just keep asking good questions. I'm not sure if my child's gut is empty. Could we just check? So I just often find parents they've been to all the right places, but they just haven't actually sort of had I don't like the word aggressive, but like a robust enough plan to actually get that old poo out or really deal with what's causing these problems. So sometimes you do have to be an excellent advocate for your kids. Same story with schools. Make sure, every child in our country has the right to attend school, regardless of their health status, and that includes their poo and wee issues. So lots of families do report that they've been told they can't attend. I would be pushing back and just encourage you to jump online and have a look at some other resources. And again, that's one of the things I'm wanting to launch, is just supports for parents to communicate in that space.
Yeah, I think it's with all health issues or anything to do with your kids, you just have to advocate,
Yes,
because you're just, the 20th patient for the day with the person that you're seeing. So your child is your number one priority, but unfortunately, it's nobody else's number one priority, and that's just life.
Yep. And taking good data is really helpful. I know on my website we've popped up like body diaries you can download and do that manually. There's lots of tracking apps and things you can do, but even just tracking so that you can see for your little person's gut or bladder what seems to help. What are those little things that seem to be helping, but not just going along, to a health professional and saying, not sure, we think it might be this. It's like, here's some data, what do you think? So that it's easier to work with sort of numbers and patterns that you can see, rather than just, a stressed parent, for example.
Awesome. I'm so glad that we've taken the time to go through and discuss all these things, because it's such a massive issue, something that we deal with every day in clinic. So now I can refer everybody back to listen to this podcast. And so thank you so much for spending this time with me today.
You're so welcome. Thank you.
I'll have links to Rebecca's website and her app and everything in the show notes, so you can look on there and get in touch with Rebecca yourself. So thank you.
Thank you so much, Lisa.
Thanks for tuning in to Holistic Health for Happy Kids. I hope you found today's episode helpful and inspiring on your journey to raise thriving, healthy little ones. Remember, small, consistent changes can lead to big transformations. If you enjoyed this episode, please subscribe, leave a review, and share it with other parents who might benefit. You can also follow me on Instagram and Facebook at the Paediatric Naturopath for more tips, tools, and inspiration. If you've got a question or a topic you'd love to hear about, please send me a message. I'd love to hear from you. Until next time, take care and keep supporting your kids in the most natural, nurturing ways possible.